Hello, Wan Lee. Jesse, is that you?
Hi, yes, yeah. I'm here. Yeah.
Oh, okay. We start
Okay.
in 15 minutes. How you
Okay.
been? How you been?
Yeah, good. Good. Yeah.
Okay. Yeah, we start in 15 minutes. Okay.
Okay. Yeah. I'm here and wait for the other the speakers and the Bing Shu.
Okay. Very good.
Yeah. Okay.
Everything
talk to you.
going good in China?
Yeah, actually, yeah, it's okay, but still, strict regular.
COVID restrictions still?
Yeah, actually, yeah. Hope everything can become back to normal. Maybe after, next month there will be a meeting of the Communist Party.
Right,
That's
right.
just
And they decide
national meeting. I'm not sure.
you have restriction now when you travel?
Actually, yes, I can travel inside China, but
Okay.
I don't think if I can, yeah, I can travel to United States, but if I want to back, still, 10 days.
Traveling is not fun now.
Yeah.
I just traveled to Boston
Oh, really? Wonderful. Oh, yeah.
and they had the same restrictions at the airport. Not many, just a mask. Just a
Okay.
mask.
Yeah, I
So-
know there. Yeah. I mean, you mean also on the flight? Oh, do, do you need wear the mask for the whole flight?
Oh, okay. Okay, I'll be back, okay?
Okay. Talk to you later.
Okay. Let me see if Jesse's here. Jesse, are you there? Is that you, Jesse? Maybe not.
Hello, John.
Yeah. Hi, Ben. How you doing?
Hi, fine.
Everything okay?
Yeah.
No work today?
Just finished.
How many today?
8.
Oh, my God. Congratulations. Okay, we start in 10 minutes. Okay.
Hello, Mustafa.
He's not in yet. I'm trying to get him in. He has this.
I found his name.
Yeah, I see his name.
赵教授好。
哎，好，Good evening, Professor 徐。啊，
Oh. Finally. Hello, Mustafa. Hello, Dr. Zhao. Dr. Bennett. Hello, Mustafa.
Good morning.
We finally
Hello,
got you.
Mustafa.
Good
Hi.
morning, John.
Hi.
And this is
Mustafa.
Wan Li Zhao. He's the
When
other
is your
host.
local time?
It's almost 6 a.m.
Okay.
I was
Thank you.
And there
so,
it's 7 p.m.?
So early. Yes.
so early. Look, this is outside, dark.
Wow,
Yeah.
wow. That's in Wisconsin, right? Madison.
Correct. Madison, Wisconsin. Yes.
Okay, great. Huh.
It is cold there. The coldest in the country, I think.
It's not cold
Minnesota,
yet, but it's going
Minnesota
to
and
be very cold.
Wisconsin. Yeah,
Yeah.
Minnesota and Wisconsin, the coldest in the country, I think.
Yeah.
Oldest.
Okay, we got 3 minutes, Mustafa. How you been, Mustafa? Thank you for coming. Thank you
You're
for making
welcome.
the
Thank you
effort
for
to get
having
up.
me. Great
Thank you for
pleasure.
making the effort of getting up early.
Of course. The reason I said 6 a.m. is I have to hit the road with my son. He has a school activity, and if I do, my wife is not in town. If I don't do it, she'll take
Oh, okay. We understand.
How old is your son?
my son is 11-year-old.
Okay.
How many kids you have, Vin?
Just one.
Just one.
One son, yes. How many?
How have you
about
been?
you?
Everything is good in China?
Yes, now we will maybe open very soon. Yeah.
Mhm. Good.
Dr. Zhao, you know how to screen share, right, Dr. Zhao?
赵教授，你要不要试一下换灯？
好的 OK
Okay, you want to test to make sure you can do it okay?
Yeah.
Do you have any videos, Dr. Zhao?
OK could you see my PowerPoint
Good,
Yes,
good, very
yes.
good. Do
Very
you have
good.
videos? Do you have videos at all?
No I don't have video
Okay, okay, you can get off the screen now.
OK I'm going to start my
No.
presentation
No,
You
not
can
yet,
close it.
not-
Yeah.
You can close
Oh,
it
okay.
now. Dr. Bin, do you want to introduce Mustafa or do you want me to? I think
Yeah,
you
you
should.
okay.
Okay, whatever you
No
want to do.
problem.
What do you want to do?
Mustafa is my friend, and
Okay, go ahead. You
Yeah,
introduce
yeah.
him then. You
Yeah.
introduce him. I'll
Mhm.
introduce you and then you. I didn't realize you guys met each other. You know
Yeah,
each other,
yeah.
Mustafa?
yeah.
Oh, very good. Okay, you ready to start, Ben?
Yeah.
Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. This is Dr. John Bennett, home of Neurosurgical TV. We have the honor of televising our bi-weekly Chinese Neurosurgical Journal webcast. And we have some great talks today, including Mustafa BASCAYA, and I'll let Ben introduce him. Welcome, Ben.
Welcome, Mustafa. Professor Mustafa is a world-famous neurosurgeon, and thank him. Today it's very early for his local time. It's only 6 a.m. and Professor Mustafa's topic is transcervical microsurgical resection of insular gliomas, preservation of the normal anatomy. So, Mustafa, go ahead. It's your time.
Thank you, Professor Bin. Thank you, John. Thank you, Professor Zhao. Thank you, all the Chinese colleagues and all the colleagues in the world. Thank you for having me. It's a great pleasure. Sorry. I hope you can see my presentation. Is it okay?
Perfect, perfect.
Okay. So this morning here in the United States is 6 a.m. in Wisconsin time, Central US, and good morning, good afternoon, or good evening, wherever you are. I'd like to talk about the microsurgical resection of insular gliomas through Sylvian fissure and how we should preserve the normal anatomy. So by preserving the normal anatomy, we'll be preserving the normal function. As you know, I am a vascular, cerebrovascular, and skull-based surgeon I have special interest in deep gliomas, brainstem, thalamus, insula, mediobasal temporal region. This is my conflict, and this is our city medicine, and the central part of the Wisconsin is the second largest city in Wisconsin after Milwaukee, but is the capital city of the state of Wisconsin. It's beautiful during the summer and spring. It gets really cold during winter, but we welcome all our Chinese colleagues and friends to come and visit us here. So insula is the island of rail, is hidden part of the cerebral cortex under the temporal, frontal, and the parietal lobes. And these are the proposed functions of the insula. And it's in reality, we don't really know we don't really know what is the true function of the insula. So when we talk about the insular gliomas, in back early times, the neurosurgeons were very afraid of going there and removing the tumors, and insular gliomas were considered inoperable until the Yaşargil starts operating and doing the surgeries, removal of these gliomas through Sylvian fissure. Many neurosurgeons were hesitant to attack these lesions. Even now, in many centers, insular gliomas don't receive the proper treatment like the other lobar gliomas. What kind of treatment alternatives we have? We have, stereotactic biopsy, and after this biopsy, radiation and chemotherapy, just radiation, surgical debulking, surgical subtotal resection, and microsurgical gross total or near total resection. Of course, every time we go there to the aim of the gross total resection. In my goal in insular gliomas, regardless the grade of the tumor or type of the tumor, gross total resection if I can. If any reason I cannot, at least a near total resection. That means more than 95% of tumor resection. What important factors in surgery is knowing the cerebral anatomy, sulcal, gyral, intrinsic anatomy of the brain, vascular anatomy, including the arteries and the veins, and then the surgical technique. So I'll just briefly go over the anatomy. And as you know, the simplest way, I unfortunately, due to the time restraints, I don't want to spend whole hours explaining the anatomy. These are easily accessible information. There are 3 short gyri and 2 long gyri and transverse gyri. So every neurosurgeon operating in the insula should know the anatomy of this sulci gyri very well, and also the variations of the anatomy. And these are the beautiful dissections and the brain sections published by my very good friend, Professor Ture from Istanbul, Turkey. And again, not only the gyral sulcal anatomy, knowing the intrinsic fibers and going these fibers going around and through the insula as extremely important to understand. Vascular anatomy, it's all vascular anatomy, the middle cerebral artery and its branches in the sylvian fissure, and they come from the M2 or M3 segments of the middle cerebral artery and supplying the insula, extreme capsule, and the classroom. Insular arteries, most of the time, they come from the directly from the M2 and M3 branches, and they supply the insular cortex. Sometimes they can supply the classroom and extreme capsule, and rarely 3 to 5% of the dissections Professor Ture performed, it may supply the corona radiata. And these are the long perforators, and we should be very careful with these and recognize them and not take them. Venous anatomy is again probably has the highest variations, and knowing the venous drainage and trying to preserve most important veins running through the sylvian fissure or around the sylvian fissure are extremely important. And lateral lenticular striates, okay, all the aneurysm surgeons, vascular neurosurgeons know about them, and we need to identify them, lenticular striate arteries, and preserve them with all costs. Okay, you cannot just take these arteries, because the result will be capsular infarct or corona radiata infarct. And around the lenticular striate arteries, we know all the supplies these important brain regions, and variations of the lateral lenticular striate arteries are extremely important. They come from the posterior inferior surface of the middle cerebral artery, most of the time from the M1 segment of the middle cerebral artery. Sometimes they come from the early M2s, and even early branches like temporal, anterior temporal, or orbitofrontal arteries. That's rare, but it can happen. And these are they go towards the anterior perforated substance, and important to recognize and preserve these arteries. Mostly now I'm going to talk about the surgical technique and how I like to do this technique. Is the basically I adopted from the Professor Gazi Yaşargil, and is all transsylvian. As you know, there are different techniques, and there are mapping technique. People who use the mapping, they like to map the inferior frontal and superior temporal gyri, and if it is not non-dominant, staying away from the lower inferior part of the motor cortex. They take the inferior frontal gyrus and superior temporal gyrus, and they go through the gyrus and go toward the insula. That's a different technique, but I like to use transsylvian technique. So that is wide sylvian fissure dissection. So you have to expose the insula all the way from the internal carotid artery bifurcation to the parietal operculum. And these all veins, arteries should be skeletonized, and to get this kind of view. And if we don't do this, and we know that it's technically challenging sometimes, but that's the best way to preserve frontal, temporal, and parietal opercula. I don't like taking any tissue. I like to preserve, and like you are doing middle cerebral artery bifurcation aneurysm or distal MCA aneurysms, you widely open the fissure. Then you identify the branches of the segments of the middle cerebral artery, including M1, M2, and M3 segments, and the branches coming from these segments and where they are going. And if the ones they go to the tumor, you have to coagulate and cut one by one. And these are the short insular perforators supplying the insula now supplying the tumor because tumor is present. And as I mentioned before, these are the important arteries to preserve because they can rarely supply the corona radiata. Then you remove enhancing portions of the tumor if tumor enhancing, and if you can, in contrast enhancing tumors, high-grade gliomas, you should also remove the parts non-enhancing T2 flare changes. A medial border of the tumor is important. That's the basal ganglia, then the internal capsule, and we use these adjuncts: navigation, ultrasound, or intraoperative MRI. That helps us to increase the safety and also to increase the rate of extent of the resection. This is again from Professor Yaşargil's book, showing all the necessary steps, opening the fissure from all the way from ICA bifurcation to the parietal opercula, and skeletonizing these veins, and skeletonizing these arteries, and then entering to the tumor and deflating the tumor. Wide sylvian fissure is the key, and preservation of the opercula and all the arteries and the veins are key. And this is how it looks before you start the sylvian fissure dissection. This is how it should look after all these cotton pedis protecting the opercula, and after skeletonizing all and the tumor removal, this should look like this. So challenges, what kind of challenges we have? We have cortex there, basal ganglia, internal capsule, vascular structures, and potential complications in the dominant hemisphere. You have language problems because you are operating through the speech centers, right? Broca and Wernicke, and you are very close to the medial structures. This is the Yaşargil classification. There are other classifications. This is simplest one, and I use this, but in reality, you don't really need any classification. Insular tumors are insular tumors. They will be purely insular and frontabasal, insular and temporomediobasal, or all of the above. So now I'd like to show some cases and surgical videos. And this is an interesting case, 45-year-old man who initially presented with the seizures. And on workup, they found this tumor at outside hospital, and they do biopsy. So you see the biopsy tract here. And they explore actually open, not stereotactic biopsy. And they do this biopsy and they say, okay, this is insular, we cannot operate. It was all arteries, MCAs were wrapped around the tumor. So you go get the radiation, and patient decide to seek another opinion and came to me, and my recommendation was surgery. And how? Through this opening, sylvian fissure. So this is that video. I'll skip this. It's just regular terminal craniotomy, and enough like strip opening of the sylvian fissure, exposure of the sylvian fissure, then sharp blunt dissection, water dissection of the Juha herniasniemi, and the different techniques. You can use peeling technique, you can use sharp dissection, you can use spreading motions, but I use all of the above, okay? And see, these veins are important, and working under the high magnification sometimes is key, and taking time, not rushing, not taking an anatomy. And this is the technique I do to avoid using the self-retaining retractors. I use this Tenno suture technique to just gentle retraction at the beginning, so my suction hand frees. And you see, this is again going through these adhesions, skeletonizing them one by one, slowly but surely stretching them and getting around them. So once we finish this, we go find the middle cerebral artery branches. So an important thing is not being subpial. So the operculum is preserved and going around it. Skip this part. So this is now we start seeing the insula. There are small, short perforators coming from the M2s and the M3s. We coagulate and cut them. And one by one, it's sometimes you have to take like 10, 20, sometimes you have to take 50, 60 of the small branches. So now I'm trying to define the frontal side of the insular circular sulcus. And once you define that, you go all around it. And then the suction then. Again, the small, short perforators going to insula. See, I am skeletonizing this, taking one by one. Okay. Then you have to debulk some to go around. You debulk the tumor, then go back to the dissection and skeletonizing these more and more, and eventually see circumferentially. You go like this, and low, using the low ultrasonic aspirator or sonopet, so you can, like in 5 or 10 settings, so you can use safely around the arteries. And final hemostasis. And this is the preoperative MRI. This is the postoperative MRI. It was grade 2 astrocytoma. And this is a elderly patients. You see there's a tumor, contrast enhancing in the insula, consistent with the glioblastoma multiforme, GBM. And again, this patient is very functional, very famous engineering professor. And he was recommended to have the biopsy, then radiation and chemotherapy. So again, the same principles. I'm going to skip this video. And Transylvian approach, wide dissection, pre-op, post-op, and this patient has been tumor-free for more than 3 years. It was grade 4 astrocytoma GBM and received radiation. This is an interesting case but it goes through the going towards the anterior perforated substance. 50-year-old nurse presented with seizures. This tumor, when you look at this, you know it's way deep, and there are contrast enhancing part and non-contrast enhancing part. These are the T2 changes around the tumor. And when I look at this, I knew this tumor was going to involve all the lenticular striates and the branches, and I was hoping it's soft tumor, but it was not, and it was encasing all these lenticular striate arteries. So let's watch this video now. Sharp dissection again, skeletonizing these veins so we can mobilize them and away from the sylvian fissure and preserve as many as you can, especially the main branches. So now as the tumor is, this is the exposure of the tumor, again, taking those small feeding arteries coming from M2s and M3s, going to the tumor. So now that's the tumor is hard, not very soft. So branches, you see these are all branches, and in my opinion, so I'm going now to the limit to temple horn. You see these all lenticular striates, and is this part of the tumor hard, but you have to give your best to preserve these branches. Otherwise, this is the patient's only and the best chance and first surgery. And I use 5 or 10 intensity sonopet around these lenticular striates and skeletonize them one by one. See, peeling the tumor off the lenticular striates and using the sonopet around them, but low intensity of 5 or 10, not more than that, because otherwise it will injure the branch. This is the final product. All arteries skeletonized. Takes hours, maybe dissection, but these are the microvascular surgical techniques, and that's why vascular neurosurgeons, in my opinion, they have much better control dealing with these arteries and the tumor and the resection of the tumor. Pre-op MRI, pre-contrast, post-contrast, blood products, and good resection, and unfortunately is great for astrocytoma. This is again another different tumor. This tumor is involving the opercula. See, the temporal side is in part in the insula, part in the opercula, and this is different. So you can do Transylvian, but you can also take the opercula because tumor partly involves the temporal, superior temporal gyrus. So, but this tumor again encasing all the branches, same techniques, using the sharp peeling, whatever it takes, and going around those veins. And if you dissect these veins, you can elongate them, and you can basically apply more traction on them. See, again, the tumor is hard, and some GBMs unfortunately quite hard and not easy to. So initially dissection, and then resection, and then more dissection as you debulk the tumor. And low setting of the sonopet. Finding the MCA bifurcation after debulking, and very, very small arteries, and it's as we remove the tumor, I think this is going to be very tough tumor, because see, it is not just a soft tumor, easily suctionable, and it's encasing some of the MCA branches 360 degrees. So I'm inspecting those branches. So this is the Lyman insular region, MCA ascending and coming up. And now this is the opercular involvement, the temporal side of the tumor. So I'm taking the cortex there because that part of the tumor is there too. So this is the some GBMs do that, but low-grade gliomas, they stay confined to the insula. They won't go to the operculum. So now we start seeing the main MCA, M1, M2 branches where the bifurcation is. So now I start realizing this is completely, and these branches, M2s, are completely encased by the tumor. So, but I'll give my best to dissect these, because otherwise we won't be able to get. And any tumor feeder going to the tumor, you can coagulate, but not going to the tumor and passing towards en passant arteries like you are doing AVM surgery, you have to preserve. Okay, so there's a tumor here, all is on the dorsal surface. I am exposing and peeling the tumor away from these arteries. These are arachnoid knives, whatever it takes, scissors, peeling, spreading, coagulating, breaking the tumor. The tumor is under this MCA. That's the proximal part of it. This is the lemon-insular region. Applying traction, counter-traction, coagulating, breaking, and slowly but surely removing this all pathologic tumor. It's hours of dissection, but it's worth to do it. And I don't suggest young colleagues to just go do these. It takes time to understand these dissection techniques and develop these. But as Professor Bean knows, you know how he's excellent in bypass surgery, vascular neurosurgery, because he spent hours working, studying these, and coming up with his own surgical techniques, right? And that's what I suggest to young colleagues, instead of taking and then just saying that I cannot remove it. Over time, do it more and more, do it more and more, and then eventually you'll be safe and you'll develop. See, I'm holding the MCA branch, I'm dissecting, taking time. Okay. Between veins, again, veins are preserved, arteries are preserved, and working in between, and if necessary, use retraction to hold the operculum, not to retract it, okay? Because as you remove it, these things can fall in your view, but this retractor, for example, no, I don't use any self-retaining retractors normally, but it's holding the operculum away from my surgical field. And you have to keep these arteries moist with the irrigation. And I also use sodium nitroprusside soaked gel foams, keep them moist. As they get dry under the microscopic light, they can get vasospasm and they can get thrombose. So be aware of that and have your assistant constantly irrigate. And these gel foams are soaked with sodium nitroprusside, but you can also use papaverine to prevent the spasm. Okay. So slowly but surely now we start seeing the finally normal white matter there. You see, and progressing as dynamic process, and removing, and until you see 360-degree normal white matter. Now we are coming towards the parietal operculum, and removing more, working between these branches until we see normal looking brain tissue. So if you work around these arteries, you also need to know if you injure them, how to repair them, right? And we vascular neurosurgeons can do that. If I have an injury here, I can put a 10-0 suture, 11-0, 9-0, whatever, and repair that area. And we vascular neurosurgeons know how to go around these arteries, not just using ultrasonic aspirator and going around and causing the problems. It goes, and I'm not giving up, okay? I could have stopped here. I said, okay, this is 90% removal, is good enough. This is a deadly disease anymore. But that's not the thing. I mean, we have to give our best to the patient. Either we are doing aneurysm surgery, AVM surgery, meningioma surgery, or bypass, or whatever, spine surgery. You have to do your best. And if possible, not only the contrast enhancing parts as guided by the intraop navigation and your sense, you remove T2 flare changes to around the contrast enhancing part. Okay? So that increases the extent of resection and disease control and better for patients' prognosis. Because we know that surgical resection is the most important key factor in prognosis of these patients, right? This is deadly disease. This patient is going to die in a year or 2 or 3, whatever. But my job is to give my best to this patient, to give the best resection possible so they can tolerate the radiation and they can enjoy the life. And by doing that, I like to preserve all these normal anatomy. I don't want to take any normal anatomy because of mapping or other things, okay? So just see, it's large tumor. Some parts are soft, heterogeneous, some parts are hard, but so what? Just keep working on it. And see, I'm slowly coming towards the end and removing all pieces. Now I'm going even extending my resection, not only the enhancing parts, but these are non-enhancing T2 changes visible on the MRI. And luckily, these parts are, as we know, is like a normal white matter, but we know that there is a cancer cells there. It's tedious, it takes time, but it's worth to do it. So this is the end. See and I'm not even happy with that part of the frontal. I'm sorry, temporal operculum, and then I resect that part. And checking all the patencies, you can do ICG green to make sure these veins, arteries, everything is flowing, and hemostasis and closure. This is immediate post-op. You see, these are blood products, not the tumor. This is a supratotal resection actually, and patient did very well, and he survived 2.5 years. Not longer than that, but we know that that's best we can do. Another patient, you see, this is the contrast enhancing parts, and there's also non-contrast enhancing parts. Non-dominant Sylvian fissure, we can do this. Same frontotemporal incision, going through the fissure. I'm sorry, I'm showing this over and over again, but these are the key things, okay? And skeletonizing all these veins and not taking them. Take the only very small ones if they are crossing the bridging veins like the ones here. But main ones you preserve. If you preserve them, it you don't have venous congestion, and you don't have the oozing from the cortex. So your venous anatomy is not disturbed, like you are doing the AVM surgery. If you take the veins early, brain is gonna be engorged. But if you do these dissections and preserve them, so then it's gonna be all good. Even the flow is slow. Once you take all these things out and start closing, it's gonna get back to their normal tone. So this is the tumor here. You see again the identifying all these gyri involved as much as you can at the beginning. Then you have to debulk, remove some tumor in order to gain space. You can do more dissection. That's the part, contrast enhancing necrotic parts. See. Now I'm going, that debulking helps me to deflate the tumor, and I'm going around. This is the circular sulcus, is going to be all circularly going around the insular cortex. Okay, so initial dissection, debulking, and then going back to the dissection and defining this from limb and insula, this temple side, then the frontal side. Any tumor going to the frontabasal or temporobasal, you go chase the tumor through this sylvian fissure opening. Retraction with your suction. I use self-controllable suctions, and your suction hand is very important. Dynamic retraction and also traction with this hand, contratraction with this hand, and that stretches the structures. You cut, you coagulate, cut, whatever. Now we come from this way in circular sulcus now towards the parietal operculum. This part is one of the most difficult parts of the insular glioma surgery, but with time you get used to, and it becomes a routine and not very stressful surgery. And I like to preserve I put the surgery cells over the operculum and this talfa pedis, so it keeps it moist, and there's no friction on the cortex. So these pedis protects the cortex from me and also light of the microscope. See the veins, eventually they will feel, it's slow, but they will feel because they were retracted. Okay, this is the final product here I like to show. This is immediate post-op MRI. I'm sorry, intraoperative MRI. We are happy, so we close. And this is immediate MRIs. You see, this is all blood products. And post-op day 2, ready to go home. And this patient actually 4 years without any recurrence and tumor progression, and 4.5 years, unfortunately, she had tumors in everywhere, and she's still around, but this is deadly disease, but I'll give her a good 4.5 years. Another dominant hemisphere, right? This is the most fearsome for the neurosurgeons, and if you do this the way described by the others, you map the area, go through here. That's not the way you should do. You should split the fissure, preserve the normal anatomy, then preserve the function of the patient. Okay, So again, this patient called inoperable due to the size and the dominant hemisphere location in the dominant insula, but it is not inoperable in reality. You can remove this tumor, and you look at this is going to be necrotic soft tumor. It's not going to be hard, solid like the ones I showed you. Okay, and we'll remove all enhancing parts and non-enhancing T2 flare changes as well. And this is preoperative, this is postoperative MRIs now. After surgery, due to manipulation of the inferior frontal and temporal, superior temporal gyri, they sometimes 25 to 30% of my patients, they have temporary speech issues, but it gets better because I didn't go through the cortex. You see, it looks as clean as this side. And this was a great foracocytoma, and patient did very well. He had probably 10 or 14 days of speech, expressive speech problems, but it cleared over time and is now more than 2.5 years. He has no tumor recurrence. And unfortunately, this patient had a beautiful video, but video got lost during the recording. So let's come to the final points. It's general thing, okay? Perfect exposure. So you just don't try to do minimal stuff and call it minimal invasive. In these tumors, you have to have a large craniotomy, and minimally invasive doesn't mean maximally safe, okay? And respect the arachnoid, and be familiarized with all these gyral and sulcal vascular anatomy. Be maximally safe, okay? Don't do right away these very challenging cases. Do a relatively easy case first, then you increase your stamina, you increase your improve your techniques, and then you start doing more challenging, more difficult cases. And in your operating room, it should be calm and nice, and you should avoid distractions in the operating room. And all kind of preventive measures should be maximized. You have to prepare yourself mentally. If there are some problems and those problems occur, you have to anticipate them and prepare yourself and prepare your team accordingly. These are all, like I said before, these are general my pearls in the operating room, and having the quiet, non-distractible, safe operating room. And please never ever give up. Be determined. Don't be minimalist because you cannot do it. If you cannot do it, find the surgeon who can do it and refer patient to that. And skeletonize all the arteries and the veins, move them away from the tumor. Be aware of the history and how people did this. And then I think in the insular glioma surgery, we are going backward. So we were not doing any surgeries, and Yaşargil started doing it. And now we are going back to the transcortical route, suctioning the cortex, mapping, all that stuff. Why do I need to map if I'm going to Transilien, right? Do you map the cortex when you do the MCA clipping? No, you open the fissure, you clip the aneurysm, you get out. the same way. You open the fissure, skeletonize these, remove the tumor, you get out. And follow your masters. And then China has so many master neurosurgeons, okay? So some of them known, some of them not known, but I know personally, I visited China twice. I had fellows from China, excellent surgeons, excellent technical skills. So use those skills to perform these surgeries, okay? And go to the lab. Use the lab as your tool to improve your skills so you can help to the patients, okay? So any neurosurgeons, in my opinion, should spend some time in the operating room improving these techniques, learning the anatomy, learning the neurosurgical anatomy, learning the intrinsic anatomy, learning the functional anatomy. And then, these things they don't occur right away. Over time, you develop, improve. I show you the videos, right? The first video I was a little more hesitant. Second video was better. So it takes time. It's not just occurs overnight. And these are the 3D slides dissection of Professor Yaşargil. He performed in I think in 1956 or 53. Look at this. He spent years in the lab before he starts operating, right? So, and when you are performing these procedures, you should be versatile. You should be aware of any problem and then overcome the problems. And neuroanatomy is your friend. So what do? You go to the lab, okay? You read, you listen, you watch, you dissect. What did Confucius say? I hear, I forget, I see, I remember, I do, I understand. I thought this is said by the Confucius, but one of my Chinese fellows said, oh, maybe that's not the Confucius, maybe some other Chinese philosopher, but whoever said it said it right, okay? If you hear it, you can forget. If you see, you remember, you understand better, maybe, but if you do it, and that's in the lab, you understand much better. So I think I'll stop here and happy to take any questions, comments, and again, I really appreciate you inviting me, Professor Bin and Professor Zhao and all the other Chinese colleagues and all the colleagues from the world. And I really appreciate Dr. John Bennett's efforts spreading the knowledge, neurosurgical knowledge, and this became a school. Okay, John, I really appreciate helping all the neurosurgeons and the colleagues. Thank you very much. Thank you for your time.
Thank you, Mustafa. I think this is my I have ever heard the most beautiful glioma resection in my experience. Thank you very much. I think you set a very high standard for the glioma surgery, and it's very impressive that you are just like treat the AVM case to treat the glioma case. Thank you. Very nice cases. And do you use some monitoring during the operation? So
yes.
And do you have some dilemma to sacrifice or keep the impulsor? Because sometimes you couldn't make sure this vessel should be kept.
Yeah. Professor Bin always asks very smart questions, and yes, I forgot to mention during my talk, I use neuromonitoring, MEPs, motor evoked potentials, and I use sometimes subcortical stimulation especially in tumors. It's going deep medially because I want to I want to orient myself about the corona radiata, location of the corona radiata internal capsule. But subcortical stimulation is overestimated sometimes, and the MEPs, they are very reliable 95% of the time, and they go down flat or reduce significantly if you cause a vascular injury. So that makes you aware you did something wrong or you are doing something wrong. And I forgot to mention, we have intraoperative MRI, 1.5 Tesla. I use intraoperative MRI in low-grade gliomas. It's sometimes, you think you are removing the tumor and you did very good resection, and you do MRI next morning. Wow, you didn't remove, you remove 80%. So intraop MRI increases the rate of extent of resection. And regarding the other question, sometimes I show you the case that's opercular case. One frontal orbital branch was going into the tumor. I couldn't save it, and I took it and coagulated. But I don't suggest doing that in every case, unless, and lenticular striates, never, because the result will be very bad.
So do you use temporal clip to test the vessel should be sacrificed? You
can, and I suggest doing that. Even you can do for the veins too. So you can temporarily occlude vein or artery and see if there's a brain engorgement locally in that location, then you cannot take that vein, or you see sudden change in the MEPs, and you cannot take that artery. And I suggest doing it every 5 minutes up to 20-25 minutes. Sometimes you don't see the changes right away, and it happens.
Yes.
It happened to me in the one spinal AVM. I put the clip, temporary clip, no changes, 5 minutes, 10 minutes, 15 minutes, 20 minutes, 25 minutes. We start seeing the change, 30 minutes, flat. Yeah. So it's very important. If you are not sure, use technology, these adjuncts, to help you to understand the physiology better. Very important questions, Professor Bin.
Thank you. I think your patients are very lucky. You did a great job.
Thank you.
Actually, I have a question.
Your patients are very lucky too.
Yeah. How do you have some special technique to to stop the bleeding if there was a very bloody GBM for some case?
Again, you see, this is like an AVM surgery, right? You saw the feeders coming from the M2s and M3s. What I did, before I went the bulk tumor, I coagulated them, cut, coagulated, cut, coagulated, cut. So that devascularized the tumor. Not 100%.
I noticed it. Yeah.
Not 100%, but it helps to reduce that. And then another key is just don't panic if you have any bleed. Just if it is major bleed, it happened one time to me. I had a major bleed from the M2 branch. I injured. Just put tamponade, go like aneurysms. You are doing aneurysm surgery or AVM surgery. Temporary clip, and you repair. But this comes over time. It just doesn't occur. When you do the bypass, first few bypass, you're hesitant. You get better every time you do. Same with the AVM surgery, glioma surgery, meningioma surgery.
Yes, great technique. I think so. That's why I said that you treat the GBM just like AVM because you control the feeders. At the first
Exactly.
step, yeah.
Exactly. If you remember the old days, when there was no MRI and no CAT scan, people diagnosed the GBMs with angiograms. If you do the angiograms in GBMs, it will look like an AVM, but is later phase, not the early arterial phase. And they ask me sometimes, how do you, because in the United States, we don't have enough AVM cases to do surgically, right? They ask me, how should we train doing the AVM surgery? I say, first start doing the GBM case and treat the GBM like AVM. Then you learn how to do the AVM surgery.
Yes, great point. That's why you say to respect the history.
Yeah.
And also, I have another question. You have a very nice post-operative MR image, and so do you do it? I mean, during the surgery, like intraoperative MR, or you just do the regular MR scan 2 or 3 days after surgery?
So if I did the case in the intraoperative MRI, yes, I do, until I'm satisfied with my resection. And next morning, next 24 hours to 48 hours, I do another MRI. Then another one in 6 weeks, 8 weeks time, after all the effects of the surgery goes away.
Okay, thank you. Yeah.
You're welcome. Thank you.
Okay, Saeed Taha, neurosurgeon from Reunion, Africa. Saeed, welcome.
Yes, thank you very much.
Yeah, do you have any comments, Saeed?
Thank you, Dr. BASCAYA, for this outstanding presentation. It's very interesting, and I think, as you told, it's hard surgery that need expertise. And if we have not sufficient number to do it, we can refer our patients to other neurosurgeon. Because if we, like you mentioned it, if we do a partial surgery, that's the patient is in a bad situation. Even if we transfer the patient to another neurosurgeon, but it's late.
Exactly. Thank you for your comments, Dr. Taha.
Thank you very much. Thank you very much.
Thank you.
Dr. Al Mekhalafi, neurosurgeon from Yemen, practicing in Germany. Welcome. Introduce yourself and make your comment, please.
Yeah, hello. I'm Dr. Mekhalafi. I'm working in Germany, in Wolfsburg, in the last 15 years, coming from Yemen originally. I have been a general surgeon and then a neurosurgeon, and we are doing also a lot of glioblastoma here in Germany. It's a very interesting cases. What you showed, it's a very, very nice results. Insula is a very, very sensitive places where a lot of surgeons, they are really skeptic to go there, not to just to take a glioblastoma, just to be there. But it's a very interesting technique, and the glioblastoma, it's one branch where we need more and more, and it's not just the surgery, target therapy, and a lot of things. We are still need a lot to do for the glioblastoma. A patient for the glioblastoma still some mysterious cases, and very, very difficult to treat. And unfortunately, also with all offers what man offered them, prognosis still very bad, even if we are talking about 6, 7, 8 years for a patient to know that he are going directly to die from this tumor. It's still a very, very sad, sad point in our medicine, what we are really trying to improve but we see that we always have limits.
Very nice. Thank you. Yeah, glioblastoma treatment is not surgery.
Yeah.
Surgery is to help them to go through these difficult times and give them the best chance and enjoy their rest of their life, whatever left. That's 9 months or 12 months or 2 years or 5 years. Future of glioma surgery will be molecular. But I'm neurosurgeon. I'm not molecular biologist. I'm not gonna find a vaccine for COVID or some unknown disease. So my role is to help the patient I have and not tell the patient that, oh, maybe 50 years from now, or there's this experimental study in somewhere. So my role, yeah, we need to understand. We need to know all these things. We need to have the adjuncts. But my role is to help the patient remove as much as mass I can safely. And so they can have so two things works in glioblastomas. Surgery plus radiation. Nothing else works well. Temodar or yeah, they help some, but two things in combination, GBM in GBMs and in general gliomas. Good surgery, good radiation in combination, not alone.
The debulking operation and radiation.
Correct. Debulking with the aim of gross total or near total.
Subtotal is total.
Yeah, it is. If anytime you do less, no benefit. There's no benefit. You remove 80% or 10%. There's no difference. You got to go beyond 95%.
Okay, Takashi Khan, a neuro-oncologist from Tokyo. Do you have any comments, Takashi? And welcome.
Yeah, thank you, Dr. MUSTAFA BASCAYA, for interesting lecture. The very fine technique of the insular glioma. So I'm a neurosurgeon treating such glioma, but the vascularity is very high vascularity. Longer insular artery. So Dr. Kumabe at the Kitasato University already reported sometimes insular artery, the longer one, and many multiple insular arteries, so very hard to remove. So in that case, so did you encounter how to treat such old to preserve all the arteries, insular arteries preserved?
Yeah, before you take them, you follow them.
All of them. Okay.
Follow them, like you are doing AVM surgery exactly. You see the feeder. You don't know it's going to the nidus of the AVM, or in this case, nidus of the tumor, until you see that entrance, right? Sometimes they come, they pass, they give site feeders. The long insular arteries, that long perforators, which are present 3 to 5% of time, very rare. They go to the corona radiata.
Yeah.
And then if you follow them, you recognize them. Only the feeder, take the feeders coming from the sides, nice, and coagulate those, but keep the main artery going to the corona radiata, and use low intensity sonopets, not also high intensity coagulation next to them. If you use it, you'll damage it. But until you are sure it's going to the insular cortex, don't take any artery.
Okay. Thank you.
Thank you.
Thank you.
Very, very good, Mustafa. I think we have to roll on. I know you're busy. Thank you for taking the time. And we'll see you soon.
My pleasure. Anytime for Professor Bin and you. If you can arrange the times, I'm happy to contribute in Chinese Neurosurgical Journal. Again, thank you very much. You guys have a wonderful evening, and I really appreciate it. Thank you very much.
Thank you.
Thank you.
Thank you.
Thank you. Okay,
Thank you.
Wan
Thank you,
Lee.
Ben.
Thank
Hope
you.
to see you soon
Thank you.
again, Ben.
Thank you.
Okay, Wan Lee, you want to take
Okay.
over and introduce
Yeah.
the speaker?
Okay, thank you. Now we have the next speaker. Actually, he is a, a cell biologist from China, Professor Weijiang Zhao, and he's from a cell biology department, Wuxi School of Medicine, Jiangnan University. And today, he will talk a little bit about the basic mechanism of the Alzheimer's disease and spinal cord injury. That's the role of L1CAM in Alzheimer's disease and the spinal cord injury, the experimental studies. So please, Professor Zhao.
Okay. Can you see my PowerPoint? Okay.
Yes.
Okay. Good evening and good morning, dear professors and colleagues. I'm pleased to present my experimental work about L1 cell adhesion molecule in spinal cord injury and Alzheimer's disease. I'm from Wuxi School of Medicine, Jiangnan University. L1 is a founding member of a subgroup of neuronal immunoglobulin superfamily. It was initially discovered and elucidated by Professor Melita Shachnar, who has been dedicated to the roles and functions of L1 in both brain development and diseases, especially in spinal cord injury, for about 40 years. L1 itself contains large extracellular parts possessing 6 immunoglobulin-like domains and 5 fibronectin type 3 repeat domains, which is linked with an intracellular domain via a single transmembrane sequence. Complex functions of L1 involve homophilic and heterophilic interactions of its extracellular domains with other cell surface molecules. And full-length L1 can be cleaved at the cell surface via extramen shedding, which can bind back to integrins via an autocrine or pericrine fashion, thus leading to cell migration, metastasis, and angiogenesis. The extracellular interaction between L1 and neuropilin-1 can lead to neuronal growth hormone collapse. Interaction between L1 and integrins can sequentially activate SRC, PI3K, MAC, ERK, thus leading to axon growth and neuronal cell migration. Spinal cord injuries, mainly caused by car accidents and high fall injury, has been among the most serious traumatic neurological diseases, and it shows an incidence of about 10 to 80 cases per million per year globally, and remains a significant source of morbidity and cost to society. Evidence suggests that the incidence of SCI in China increased dramatically during the past decade, and with an incident rate ranging from 20 to 60 per million per year in China. Pathologically, spinal cord injury can be characterized by the formation of the fibrous core and the glial scar. The fibrous core is derived from the meningeal and vascular endothelial cells, and reactive astrocytes form the glial scar surrounding the central core on both sides, thus inhibiting the extension of the regenerated neuronal fibers into the lesion core, and thus reach the opposite, reach the caudal side of the lesion core. Previous experiments demonstrated that overexpression of L1 via adeno-associated virus in the injured spinal cord can significantly promote the growth of serotonin-positive fibers into the lesion core. The fibers had reached the caudal border of the lesion core and extended beyond the border and entered the caudal site of the spinal cord. Overexpression of L1 via adeno-associated virus in the astrocyte can significantly inhibit the migration of astrocytes. And basal mouse scale evaluation demonstrated after the treatment using AAV L1, the locomotor function can be restored to about 50% of the normal level. In addition, soluble L1 FC treatment can also improve the locomotor recovery in rats after spinal cord in compared to those injured rats treated with PBS. However, there is a problem. The molecular weight of L1 chem is very high. So we asked if there can be another alternative method that can stimulate the therapeutic function of L1. We then sort to the antibodies that may be used to trigger the function of L1. The protective antibodies, including those targeting CD11D, tumor necrosis factor alpha, and interleukin-6, have been reported to counteract the secondary injury to inflammation after spinal cord injury and lead to minimized neuronal cell death and functional recovery. We then used the phage display to target the third fibronectin type 3 repeat of L1 to screen an agonistic antibody that can promote the therapeutic function of L1 to trigger neurite outgrowth, neuronal cell adhesion, and neuronal cell migration. Our results demonstrated that we obtained several agonistic L1 antibodies that can efficiently bind to their targeted domain of L1. We then use in vitro experiments to test the therapeutic effects of the agonistic I1 antibody. Our results demonstrated that administration of the two L1 antibodies can profoundly and dose-dependently increase the neurite outgrowth of SKN acid cells. In addition, the L1 antibodies can inhibit adhesion to fibronectin while promoting cell migration of U87MG cells. We then tested the underlying mechanisms for the therapeutic of the L1 antibodies. We found that administration of L1 antibodies can significantly enhance both ERK and the STARK signaling pathway, which have been reported to be highly related to neurite outgrowth and neural regeneration. We then test the therapeutic antibodies using a forceps compression model of spinal cord injury in mice. Our experiments demonstrated that cross-examination showing our L1 antibody can partially protect the spinal cord, as was observed by the formation of the glial scar. Yeah, we can see that in vivo treated spinal cord injury mice, the glial scar formation can be observed by naked eyes. However, in injured mice treated with the L1 antibody, we couldn't see the glial scar with naked eyes. Immunohistochemical staining also demonstrated that L1 antibody treatment can profoundly inhibit the activation of microglial cells in most of the spinal cord areas, as was indicated by the staining intensity of CD68. Similarly, we found that the L1 antibody administration can also inhibit the spinal cord injury-induced expression of GFAP. We then use immunofluorescence staining to test the therapeutic effects of L1 antibody on the formation of glial scar. We can see in vehicle-treated injured mice, the glial scar formation is very obvious. However, in injured mice with L1 antibody treatment, the formation of glial scar, as was indicated by the expression of GFAP, was significantly inhibited. We can also say beta-3 tubulin positive neuronal fibers were also observed in the lesion center, suggesting the L1 antibody can inhibit spinal cord injury-induced glial scar formation. We then use locomotion functional assay to test the therapeutic effect of L1 antibody. We can see by using BMS score, the L1 antibody can significantly improve the locomotor function of the injured mice. However, we can see that as time goes on, the therapeutic effect of the L1 antibody decreases. So we are facing problems for further studies. The first is how to increase antibody yield while reducing production and purification cost. The second is to how to improve binding efficiency of antibodies with better blood-brain barrier penetration and experimental treatment effect. Okay, next, I'd like to talk about the roles of L1 in development and treatment of Alzheimer's disease. We know that Alzheimer's disease has been recognized by the World Health Organization as global public health priority. It is clinically characterized by acquired progressive cognitive impairment sufficient to impact on activities of daily living. And pathologically, it is characterized by diffuse atrophy, widened sulci, and narrow gyri, and enlarged ventricles. It is also characterized by deposition of beta amyloid plaques, as well as reactive microglial cells and neurofibril tangles. Alzheimer's disease is now threatening 44 million people worldwide, and it's predicted to be more than triple by 2050 as the population ages. So we ask if there is something if L1 can function in the prevention and the treatment of Alzheimer's disease. To prove our hypothesis, we first crossbred L1 deficient female mice with APP-SW AD transgenic male mice on the C57BL6 background. And the female offspring containing both APP-SW transgenic genes and L1 deficient genes were maintained until the age of 1 year. And we can see by both immunohistochemical staining and immunofluorescence staining, performed the formation of a beta positive plaques formation were formed in both prefrontal cortex and the hippocampal cortex in the AD mouse with L1 malfunction, suggesting L1 malfunction may increase amyloid plaque loading in AD mice. The histone histolase 2 has been HDAC2 has been reported to prevent the transcription of genes that are important for synaptic plasticity. We then studied the effect of L1 malfunction on the expression of HDAC2 by using histochemical staining and immunofluorescence. We can see a profound increase of HDAC2 levels in both prefrontal cortex and hippocampus in 80 mice, suggesting that L1 malfunction can promote the expression of HDAC2. We then test the effects of A-beta on the expression of HDAC2. By both RT-PCR and Western blot, we can see that in vitro administration of oligomeric A-beta can significantly induce the expression of HDAC2 at both mRNA and protein levels. However, administration of recombinant L1 can significantly inhibit the effect of A-beta on HDAC2 expression in both cortical neurons and hippocampal neurons. The same results were also found in cortical neuron and hippocampal neuron cultures. In addition, we also know that the phosphorylated activation of glucocorticoid receptor 1 have been reported to play a critical role in regulating HDAC2 gene transcription, and the function of GR1 on HDAC2 expression is through its activated functional phosphorylated form, PGR1. We then administered cultured cortical and hippocampal neurons with A-beta. We found that A-beta can significantly induce the phosphorylated activation of glucocorticoid receptor 1, which can be inhibited by GR1 inhibitor. We then test the effect of GR on the nuclear translocation of HDAC2. As was indicated by the immunofluorescence staining, we can see A-beta administration can significantly induce the nuclear translocation of HDAC2. However, administration of GR1 inhibitor can significantly reduce the nuclear translocation induced by A-beta in hippocampal neurons. So these results indicated that inhibition of glucocorticoid receptor 1 activation reduces enhanced HDAC2 expression levels induced by A-beta treatment in cultured hippocampal neurons. We then test the effect of A-beta on GR1 activation and the therapeutic effect of recombinant L1. By using Western blot, we can see that in vitro administration of A-beta can apparently induce the phosphorylation-mediated activation of GR1 in both cortical and hippocampal neurons, while administration of recombinant L1 can dose-independently reduce the phosphorylation mediated activation of GR1, suggesting that L1 can reduce A-beta-induced GR1 activation in cultured neurons. We then test the effect of L1 malfunction in HDAC2 levels by using in vitro culture of cortical neurons. We can see that L1 malfunction can significantly induce HDAC2 expression and phosphorylated activation of GR1, which can be further enhanced by administration of A-beta. while co-administration of recombinant L1 can significantly reduce this effect. Thus, these results suggest that L1 reduces L1 deficiency, induced elevated levels of HDAC2 and glucocorticoid receptor 1 activity in cultures of cortical neurons. Thus, collectively, our results demonstrated the inhibiting role of L1 on HDAC2, which contributes to ameliorating the phenotype of AD by GR1 dephosphorylation. These combined findings encourage further investigations on the beneficial effects of L1 in the treatment of AD. So that's part of my experimental work about L1 in spinal cord injury and Alzheimer's disease. I'd like to extend my gratitude to my previous and present colleagues and students, especially Professor Melita Shagnar. Her devotion to neuroscientific research has been inspiring me to continue my experimental work. Thank you.
Thank you, Professor Zhao. Yeah, I think you give us a comprehensive introduction about your basic research focused on the both Alzheimer and spinal cord injury. Can you give us a little bit more explanation about the relationship between Alzheimer and the spinal cord injury? So why you focus both two disease? I think for me, I think that's kind of different.
Okay, yeah. So actually, I don't think there are a close relationship between spinal cord injury and Alzheimer's disease. But actually, L1 cell adhesion molecule can function in both conditions. So my focus is the molecule, L1 cell adhesion molecule, because it has been reported L1 adhesion molecule malfunction being observed in both spinal cord injury and Alzheimer's disease. So I want to say if L1 can exert some therapeutic effects in the pathological conditions of the two diseases. Yeah, the really focused is L1 cell adhesion molecule. Yeah.
Okay, thank you. Do you
okay?
Are there any questions from the?
Okay, Professor Zhao, very nice presentation. But do you think that after the injury of the spinal cord, is it possible to use this treatment? But at first, we should make the spinal cord connected.
Actually, you know, I'm a neurosurgeon. I don't know I actually don't know the development of spinal cord neurosurgical treatment for spinal cord injury. But for me, it's really difficult to link the both sides of the leading side. I think in the future, drug treatment is still the main focus of spinal cord injury. For counteracting the spinal cord injury. Nowadays, small molecular compounds have been reported to be more effective in the treatment of neurodegenerative diseases and other traumatic neuro diseases. So I think in the future, maybe for a long time, we still have to have to focus on the treatment, on the application of drugs for the treatment of spinal cord injury. Yeah.
Yeah, thank you. I think it's a very important aspect of the spinal cord injury, the scar formation. But the real spinal cord injury is more complicated because it's also have some vascular injury and some ischemic condition. Yeah, so it's more complicated than the scar formation.
Yeah, it's really hard work. Yeah.
Yeah.
I don't see any comments in the panel. Ahmed from Afghanistan, do you have any comments or questions? You haven't checked in, Ahmed. We'd like to welcome you from Afghanistan, where he's the president of the Neurosurgical Society. Perhaps he's not able to connect. Okay, any other comments before we close from anybody? Okay, if not, we're gonna have Chandra Diopujari, an Indian neurosurgeon, in 2 weeks, and I'll send you the information, Ben. How do we do in China today with Mention, Ben?
I beg your
Okay,
pardon.
thank you.
Okay, thank you.
I think 2 weeks from now there will be Chinese National Day holiday.
Yes, yes.
Oh, okay.
So I think
Yes.
maybe we can postpone the next webinar to October 9, the Sunday.
Okay.
3
Okay,
weeks.
we'll talk about that.
3
We'll
weeks
communicate.
from now. Yeah. So because
very good.
October 2nd, there will be national holiday. The
I
whole week.
understand. Okay,
Yeah.
I'll note that. I'll note that. Okay. Wan Li, thank you. Dr. Ben, thank you very much as
Thank you,
always.
John.
And thank you,
Yeah.
Saeed, Weizhang Zhao, Takashi,
Okay.
Dr. Al McHoffley from Germany, and everyone else for coming, and Takashi. Okay, we'll see you maybe in 3 weeks.
Thank you.
Yeah.
Thank you.
Bye. Bye.
Okay, thank you. Bye-bye.
Bye. Thank you.
Okay, we've stopped the televising, and we can network if you want.
Okay.
If you
Yeah.
guys want to meet these guys, Dr. Zhao, he's not an easy guy to meet, I'm sure. In Beijing. Yeah, how many residents do you have in your program, Dr. Zhao?
Oh yeah, both Dr. Bing Xu and me, we work in 2 largest neurosurgical center in China. For me, it's in Beijing, and for Dr. Xu, he's in Shanghai. We both have more than 100 neurosurgeons. Almost 200, but they're about every year we have about 10 neurosurgical residents. The new residents enrolled in our department. So yeah, after 5 years training, they can be the kind of junior consultant.
Okay.
Like
Now, when you have conferences in the hospital, do you televise them at all, or they're closed to the hospital?
you mean the
The M&M reports, the grand rounds. Do you have a grand rounds in your hospital?
of course, yeah.
Well,
Yeah.
that's the thing I'd really like to televise, if you guys are interested in televising it, maybe, if you want.
Yeah, we had tried to do the the internet grand round with I remember that's with Cleveland Clinic.
Oh, they did it? Oh, okay.
With 2 hospitals do the grand round at the same time through the internet.
Well, you
Like-
know, if you put me in touch with them, I could go to their feed and take their feed.
Yeah.
Give them another way to distribute it to a different audience.
Yeah, I know. Yeah, that's
Yeah,
very
just put me in touch with them. I'll be glad to work with them to spread,
okay.
to spread the knowledge, to spread,
I know,
to
I
make
know.
it wider.
Yeah. We can also introduce our experience. Yeah,
Great.
to
Great, very good. Okay, then, we'll see you
Okay.
guys probably in 3 weeks.
yeah. Okay. Thank
Bye-bye.
you. Bye bye.